a background of how this intervention came about. So it all started with a lot of research on depression, in persons living with HIV/AIDS, where we found that about 30% of persons with HIV/AIDS have depression. Both the depression symptoms and even the full-blown disorder has been healthcare associated. Poor adherence to art. So these persons don't do very well on their treatment. They continue to have poor health outcomes and poor social economic outcomes. And when I looked at the other forms of counseling, individual, family, there was no difference between those, let's say, who opt for family versus those who don't. But for counseling, it was really evident. And you know our problems of scarcity of medications, stock out, especially in the rural areas. Everyone has been given antidepressants. Then they run out of stock, meaning that the people who really need them don't even have that few which is there. So we really needed to introduce this culture of giving people counseling first. And that is what this intervention is all about.
When I went through Module 1, in relation to my practice, actually I was reviewing this, looking at myself in practice. I was trying to apply it here. To my observation, it meets what it's set out to, what it's meant to cover up in the field. Much of the work that I really saw, I found in Module 3, and that's where most of my comments are. From the beginning, describe what mental health is, find all that was good. I found it really broken down to cover the emotions, thinking, behavior, and perception. But when it comes to sadness, it says sadness is something we all experience. It's normal. It's a normal human emotion. We experience it when we experience something unpleasant in life, such as a loss, disappointment, and so on. But now when we come to sadness is what happens when we get a divorce. Sadness is what happens when we are stood up for a date. I found that a bit unrealistic. Not everyone who gets a divorce is sad. There are some people who get a divorce, but they're okay with it. Me getting divorced does not mean I'm going to end up being sad. So I found that a bit unrealistic and not applicable. Difference between sadness and depression. Sadness is not constant. Sadness is not an every moment of everyday thing like depression is. Sadness relents, depression doesn't. So sadness may usher in negative thoughts, but it does not propel a person into a place of suicidal ideation.
I don't know, can I make a comment?
Please.
Yeah, so because with low to moderate depression, people can try to mask it and even pretend to be happy, especially if they fear that they will be misunderstood, especially men. Yes.
But if you assist
yes, it will come out.
Pretense does not take long, at least at some point.
And when they refer it is the clinician who now knows this is a psychotic depression, not another form of psychosis.
Yeah.
Then eventually you find you explain these ones. But now, as I'm saying, in their money it should not appear.
So sadness does not produce significant weight changes or prolonged period of sleep changes.
It is not there.
It's not there, so maybe I would think we are safer
In the SRQ, that's not there. It is not there.
Depression does not always include psychosis. But maybe we can add depression in men.
I think the psychosis.
But the way it is here.
That is the severe.
Because we are not expecting them to manage depression, psychotic depression.
Oh, yeah.
Because they meet their symptoms of psychosis. We don't expect a lay person to now do that. They have to refer. And when they refer it is the clinician who now knows this is a psychotic depression, not another form of psychosis.
Yeah.
Instruction to the facilitator to go the Venn diagram.
Yeah.
So that
Yeah.
And I think they are writing on the chart.
So steps in screening for depression. The following is a suggested procedure for screening a group of community members for depression or any other emotional need. Screening should occur before official mental health testing. Participation is, of course, voluntary, optional. Step 1. Introduce yourself to the people to be screened and give a health talk on depression, emphasizing the importance of screening. Hand out screening tests to those who would like to be screened. Look at the score and assess level of functioning and make referrals. Review in private the concerns with each individual who took the test. If there are no signs of severe depression, e.g. suicide attempt, psychosis, offer treatment with group support psychotherapy. If there are signs of severe depression, refer to a mental health worker at the closest health center.
Those that have the symptoms, who feel for which they have talked about, you can come and we screen you
So
further.
where is the health talk now?
At the health center.
Yes, I'm saying, but where?
Yeah, it should be clear
Where is it here?
who is doing
The health talk.
who is doing
Introduce yourself to the people to be screened and give a health talk on depression,
who are the people.
emphasizing the importance of screening. So at a health center, people have come and they are waiting. They're in the waiting area. It's the day of the HIV clinic. People have come.
They are waiting there. So they have to have a short fact
A
sheet
short talk
of the talk
on
No
depression.
introduction.
I think that the evidences are going to change. You find it difficult to enjoy your daily activities, especially in the evening. The same cooking there in the background. So this will not apply very well.
To a man. Yeah, so it's something else. It's a different illustration for the man.
Different. Most of them are.
Some are same, but some are
The male version.
The things are different. The activities illustrated are also different.
People need to be because help people to understand that depression is a serious matter. It is a cause of death. In fact, I will tell you this is maybe because the schizophrenia, they struggle with their schizophrenia. And because of heredity, they don't feel themselves.
And the person comes, they have been handling coping strategy. Their distress is a little bit during the psychiatric interview. Because we're talking about painful
So they accept their depression.
then after it starts to go down. So now
We sort of re-traumatize them somehow.
this person interprets that hey, things have gone up. Refer.
Because depression is a very complex issue. So in such a sentence, it is helpful.
To me,
Because now people,
I'll look at
for
it
example,
more on the side of how they perceive their illness. If somebody starts to talk about how they are lost hope,
But in this intervention, we don't assess the symptoms every after session. We assess at the end, either halfway or at the end. So S is for sex, either male or female. A is the age. Young males and elder people are more at risk. D is for depression. If the mental problem, someone has depression, the risk is greater. P is the previous attempt. If someone has had a previous attempt, their risk is high. E is for ethanol. If someone is using alcohol, the risk is also high. Then R is rational thinking, which means psychosis. Then S is the social support. If someone has no support, has no relatives, lives in his hut by himself, the risk is greater. Occupation, not job, jobless. N is for no spouse. People living by themselves.
It seems to sieve out all those things we are trying to make a write-up for to solve this problem.
The other key counseling skills we're talking about is self-disclosure, which requires that the counselor reveal some information about him or herself to the group. For example, when the counselor realizes that it is necessary to cause a positive effect to the group process. Then the other skill we want them to have is confrontation, which is an attempt by the counselor to gently bring about the awareness in the clients of something they may have overlooked or avoided.
With adults, the more confrontational you become, they become
defensive or close up.
Yeah, it has to be done not in the beginning stages of the group.
One of the facilitators told us that he also had an issue and was relating with the people within that group. So somehow we became part of the group for discussing issues that were, I think, where we were also feeling as part of it, not as a facilitator, but even as a participant. So I don't know what happens in such a situation, like in GSP, what happens.
They may disclose to a certain extent. Actually, we talk about disclosure.
But if it is your issue,
they can disclose their issues. Use eye contact if culturally appropriate. Ask purposeful questions that show your interest. Show that you trust and respect the other person. Be non-judgmental to the views of the other person. Find out their reasons for their views. Be assertive, honest, genuine. And when you're speaking, be enthusiastic and appropriate, and use self-disclosure appropriately. What we've been discussing. Helps the individual grow emotionally and solve personal problems. All utilize the power of the group as well as the facilitator who leads this process. Then universality of problems, hearing from others with similar issues helps you to see that you're not alone in having challenges. This discovery helps many people experience a sense of relief. So I think it will be treatment for them as well. We plan to counsel patients with depression and HIV. So how do we overcome this stigma? So by knowing that others experience situations of stigma, that itself, they makes them know that they are not alone in regard to that issue of stigma. It's not only them who experience stigma, but actually in everyday life experiences, you can be stigmatized. If you stand out with some condition, like this example, I often talk about how I grew to 6 feet tall before I was 12 years old and was laughed at and discriminated at. Because everybody else in my class and all the boys were so much shorter than I was. So there are those experiences we go through as we are growing up, whereby you may stand out from your peers, then they pick on you because of that attribute that you have.